Well, welcome to Menopause 101. I am Brittany Quinn. I'm a women's health nurse practitioner, and I own Therapy Women's Health. We have two locations, one in Alpine, one in Jackson. And there's the contact info if anybody needs it. This is my family. Most of you already know Skyla for sure knows, but yeah, that's us. And then a lot of people have questions about what is a women's health nurse practitioner. So advanced practice registered nurse, which is also called an APRN. We either have master's or doctoral degrees, and they're client-centered primary care and specialized care for women, all gender identities from puberty through adult lifespan. So we provide primary gynecological, pre and postnatal care, order and interpret tests, make diagnoses, order treatments, perform procedures, and prescribe medications. So, and then how and where do certified women's health nurse practitioners provide care? All sorts of different places. I mean, we immunizations, STD checks, sexual health, mental health, genetic screening, brain health, fitness and nutrition, and then along with all of those other things, ending with menopause, but basically just taking care of women throughout the lifespan. We can have our own private practices, depending on which state you practice in. You don't have to have physician oversight, community health centers, health departments, hospitals, and so on. Both independently and collaboratively as members of the healthcare team. So we provide leadership to improve women's healthcare and health outcomes, consultation to other healthcare professionals that don't have as much experience in women's health. And menopause, a normal natural event defined by the final menstrual period and confirmed after 1 year of no menstrual bleeding. It represents the permanent cessation of menses resulting from the loss of ovarian follicular function, usually because of aging. Normally occurs between the ages of 40 and 58. The average age is 52. Women worldwide are living longer, so more women are living their lives in menopause, which has led to more conversations about improving the quality of life. And more than 60% survive at least until 80 years old. So 40% of their lives in postmenopause. And this is some terminology. When you go through premature menopause, it's called premature ovarian insufficiency. That's when you go through it before age 40. Early menopause is 40 to 55. Perimenopause is variable. Menopause, like I said, average age 52, but the range is 40 to 58. And postmenopause, after you've gone through that year of no periods, that is postmenopause, and that can be variable. This is a graph of the changes in the estradiol and FSH, follicle stimulating hormone. Units of hormone are marked in the corresponding curves during the menopause transition. Basically, decreased ovarian sensitivity to gonadotropin stimulation, which results in decreased estradiol production, decreased negative feedback to the hypothalamic pituitary adrenal axis results in increased FSH and increased luteinizing hormone. And principal symptoms affecting the quality of life are usually vasomotor symptoms like hot flashes and night sweats, mood changes, cognitive changes, sleep disturbances, increased weight, change in body habitus, genitourinary syndrome of menopause or GSM, sexual dysfunction, and changes to skin and hair. Other health concerns in the menopausal period are osteoporosis, cardiovascular disease, and certain cancers. Symptoms often start before the final menstrual period, so in that perimenopause range during the menopause transition. Multitude of symptoms may occur with varying degrees of bother, but there is no one menopause syndrome. Everybody experiences it differently. Vasomotor symptoms affect up to 80% of women during the menopause transition. So you can see most are in the perimenopause and postmenopause category that reported symptoms, but an average of about 7.4 years centered around the final menstrual period, but may continue for 10 years or more. It's more prevalent in these populations: African American women, Hispanic, non-Hispanic, white women, Chinese women, and Japanese. The earlier the onset of menopause, depression, anxiety, stress, less college education, financial strain, single, smoker, a poor social situation, and then if your BMI is over 30, which is in the obese category, is associated with a longer duration of symptoms. So approximately 10% experience vasomotor symptoms for more than 20 years. So it's nothing to just live with, forget about. This is the genitourinary syndrome of menopause. So it's a collection of signs and symptoms associated with estrogen deficiency that can involve the vagina, vulva, bladder, and urethra. Symptoms must be bothersome and not caused by alternative diagnoses. They're often chronic and progressive, unlikely to improve without treatment. Vulvovaginal atrophy is a component of this syndrome that describes the appearance of the genital tissues, but it's not indicative of symptoms just because the tissues look like that. The genital symptoms are dryness, itching, burning, irritation, vaginal discharge. Urinary symptoms include pain with urination, nighttime urination, waking up to pee, urinary frequency, urgency, recurrent urinary tract infections. Sexual symptoms can include decreased lubrication, arousal of sexual activity, pain with insertion during sexual activity, pain with intercourse, decreased or delayed orgasm, and post-coital bleeding. So estrogen maintains the blood flow to the vulvovaginal tissues, which stimulates collagen, hyaluronic acid, and mucopolysaccharides within the epithelial layer. And the estrogen is associated with a decreased vaginal pH of less than 4.5, and that indicates a healthy balance in the vagina. Estrogen receptors are found throughout the vagina, vulva, urethra, and trigone of the bladder even. Loss of this estrogen results in thinning of the vulvar tissue and superficial epithelium, and loss of vaginal rugae, labia minora, and vaginal elasticity. And narrowing of the vaginal canal, pore distension, decrease in glycogen, lactobacilli, and lactic acid, which are the good types of bacteria that you want in the vagina. And decreased blood flow, higher vaginal pH, leading to an increase in lymphocytes and plasma cells, which get the balance off, and you can have things like yeast infections, bacterial vaginosis, things like that. And then the opening of the vagina with a shorter proximity to the urethral opening. So sleep disturbances in menopause, this is one of the things that people come to me a lot with because they usually have the night sweats, which are hot flashes in the nighttime. Difficulty sleeping and insomnia are common. And during the menopause transition, women with vasomotor symptoms are more likely to report disrupted sleep. Night sweats, sleep disturbances can be present whether they have hot flashes or not. 38% of women in the SWAN study reported aged 40 to 55 reported difficulty sleeping. So the highest rates of sleeplessness in late menopause or surgical menopause. And then contributing factors, they're listed, but night sweats, aging, stress, social and psychological factors, certain drugs, alcohol, poor sleep health, and other comorbidities. Sometimes people have obstructive sleep apnea, restless legs, thyroid disease, diabetes, anxiety that also contribute. The effects of sleep dysfunction on quality of life and health. So obviously associated with fatigue, irritability, chronic illness, along with negative effects on mood, worsening depression, weight gain, and then it can increase your risk for metabolic syndrome and higher association with coronary cardiovascular disease. Factors in the expression and experience of depression. Personal history of depression increases your risk of having more severe depressive symptoms in menopause. Overall poor health, the severity of your vasomotor symptoms, sleep disturbances, cognitive changes, surgical menopause, changes in weight, and it goes on. And then the psychosocial stressors that contribute to mood changes, This was an interesting term called the sandwich generation, where they're caring for both children and aging parents, and also changes to physical health in self and your partner. Role changes like an empty nest, death of parents, possible changes in marital status, and kids leaving the home. Although every woman is different, they have found that some are more sensitive to the hormone changes. And I've also referenced this to my patients too, but these women may experience increases in symptoms such as depression and or anxiety during times of hormonal changes, which mimic the premenstrual period, pregnancy, and after the postpartum time period as well as during the menopause transition or perimenopause. So it kind of mimics those time periods when your estrogen levels are low. Antidepressants are an option. Many used to treat vasomotor symptoms of menopause, also treat depression. And then psychotherapy. Therapy is always great to incorporate at any point. And then estrogen therapy. It's not FDA approved to treat mood disorders, but researchers have found that it may be almost as effective as the antidepressant medications typically used to treat depression in certain women.
Did you say that was the psychotherapy or the estrogen therapy?
The estrogen therapy, yeah. So that is almost as good as antidepressants. And then complementary medicines, it helps with in some people in some settings, but not enough evidence to support that, like herbs or supplements. Muscle and joint pain in menopause. So musculoskeletal pain, joint pain, and arthritis are all more common in postmenopause, and it may be transient and self-limiting. But if it's chronic, then you need to rule out other causes that are listed. And then more than 50% of women report joint pain at menopause. So the role of estrogen in all of this. Estrogen has a complex involvement in joint health. It has positive effects on cartilage metabolism, positive effects on balancing inflammatory reactions, and then joint pain seen in other settings of acute estrogen withdrawal if they go off of certain medications or start on certain ones. You can tackle it with conservative treatments like exercise, weight loss, analgesics, but if it's persistent, then hormone therapy may alleviate the joint pain. The Women's Health Initiative was a study that determined that women on hormone therapy have less joint pain or stiffness compared with placebo. And then estrogen alone use resulted in sustained reduction in frequency of joint pain and fewer joint replacements. Skin changes can also occur due to lack of estrogen. 60% of women seen in menopause clinics report skin problems. So dryness, itchiness, thinning, wrinkles, poor wound healing, sagging, and the list goes on. Factors affecting skin changes: genetics, aging, 30% decline in skin collagen in the first 5 years after menopause, and then 2% per year of decline over the next 20 years. So those are intrinsic, so things you can't really do much about. And then extrinsic factors like ultraviolet lights, smoking, alcohol consumption, pollution, poor diet, sleep deprivation, and a decline in estrogen. The effects: estrogen receptors are present in significant numbers in the skin. So estrogen decrease is associated with decreased cellular growth factors, repairing, and vasculature. So less elasticity, dryness, skin barrier disruption, and dermal thinning. Estrogen therapy may benefit wound healing through modifying inflammation. It has benefits on skin thickness, collagen elasticity, and improved skin moisture with fewer wrinkles. Estrogen deficiency melasma is not related to pregnancy melasma, so related to visible sunlight or exposure. It's easier to prevent than treat. And then hair changes. People come to me a lot with hair loss and thinning. Not everyone experiences changes in their hair, and the symptoms vary widely in those that do. So reduced hair growth on your scalp. You can have certain increased hair shedding, and that's the fancy term for it. And then hirsutism, which is unwanted hair growth on the facial areas. Hair growth aberrations can have a negative effect on body image, self-esteem, quality of life, emotional well-being. Factors affecting hair changes. The exact mechanism of female pattern hair loss is unclear. However, it seems to be related to an inflammatory process and altered hormone imbalance, along with environmental and genetic factors. So we kind of went over those intrinsic and extrinsic factors that you either do or don't have control over. Weight changes in menopause. So obesity is considered a BMI of over 30 in the United States, and it disproportionately affects women. The U.S. National Health and Nutrition Examination Survey in 2018 showed 43% of menopausal women were in the obese category. 2/3 of women aged 45 to 59 and 3/4 aged 60 years and older are overweight. So that's a BMI of over 25. Half of both groups have obesity, and then weight gain at midlife is related mostly to aging and lifestyle, not menopause or hormone issues. So factors affecting weight gain: sleep disturbance, decreased metabolic rates, decrease in lean muscle mass, and increase in fat mass. Alterations in the gut microbiome are associated with estrogen deficiency, which may affect absorption and metabolism. Loss of ovarian function and the cessation of the luteal phase of the menstrual cycle. Decreased physical activity secondary to physical limitations, fatigue, work demands, and mood changes. So health risks associated with weight gain at midlife. Most people know this, but you can have metabolic syndrome, type 2 diabetes, cardiovascular disease, aortic plaques, liver issues, breast cancer, and obesity is also associated with an increase in severity and frequency of vasomotor symptoms in the menopause transition. And then abdominal obesity is more consistently associated with obesity, rather related comorbidities than BMI. So menopausal symptoms and sexual desire. The loss of sex hormones can be associated with low libido, decrease in orgasm response. Lack of estrogen can lead to structural changes in the vagina, vulva, bladder, leading to decreased vaginal lubrication, dryness, and pain with penetration. So symptoms that negatively affect sexual desire: overall, not feeling like yourself because hot flashes, night sweats, decreased sexual function, mood swings, irritability, weight gain, fatigue, lack of energy, and trouble sleeping. Abnormal uterine bleeding. So menstrual flow outside the normal volume, duration, regularity, or frequency. This happens for some women in the perimenopausal and menopausal areas, but it's an umbrella term that encompasses heavy menstrual bleeding and intermenstrual bleeding. So it accounts for 1/3 of visits to the gynecologist and 70% of all gynecological consults in the perimenopause and postmenopause years. So the palm coin classifications are just things that can cause this bleeding. So structural causes like polyps, adenomyosis, fibroids, and malignancy, and thickening and abnormal cells in the lining of the uterus. And then non-structural changes include clotting disorders, ovulatory dysfunction, endometrial iatrogenic, which just means we don't really know, and then not otherwise classified. And then perimenopausal abnormal bleeding, it's irregular ovulation and insufficient progesterone during the menopause transition leads to premature and irregular shedding of the endometrium. For some, bleeding can be heavy and prolonged, contributing to compromised health and impaired quality of life. Although abnormal uterine bleeding during the menopause transition is common, it's important to differentiate between normal physiology and underlying pathology. Even when the bleeding is not heavy or prolonged, it can significantly affect quality of life, and treatment should always be offered. Any bleeding, including spotting, postmenopause, warrants evaluation. That's one of the pearls, is that if people have issues, any spotting, any periods after you've gone a full year without a period, you have to definitely go back and get that checked out, because it can be the first sign of endometrial cancer, which we'll talk about. So hormone contraception, despite a decline in fertility, pregnancy is still possible. So some people choose to stay on hormone contraception to make sure they don't get pregnant, plus control menopausal symptoms. There's lots of options like low dose combination pills. Progesterone only contraception can be used if people have contraindications to being on estrogen, like tobacco users, uncontrolled high blood pressure, and then blood clots. So there's also IUDs, which are nice because you don't have to remember to take a pill every day. And then there's also injections, though, too, but they can be associated with weight gain and lower bone mineral density, which makes it less ideal in this patient population. Transitioning from hormone contraception to hormone therapy. Everybody's different. Some people may continue contraception until the typical age of menopause, or when 90% of women reach menopause, which is about 55 years old. They can transition from hormone contraception to hormone replacement if still symptomatic, but hot flashes may reappear transiently because birth control has higher hormone concentrations than hormone replacement. FDA indications for hormone therapy use: vasomotor symptoms, prevention but not treatment of bone loss or osteoporosis, treatment of premature hypoestrogenism because of hypogonadism, if you got your ovaries removed with a hysterectomy or for other reasons, premature ovarian insufficiency, and then GSM as well. Contraindications: unexplained vaginal bleeding, prior estrogen-sensitive cancers like breast, ovarian, endometrial, triple-negative breast cancer. However, the use of hormone replacement in symptomatic individuals may be considered if it's 5 years from your diagnosis or treatment has been completed. History of coronary artery disease, stroke, and myocardial infarction or heart attack. History or inherited high risk for blood clots. And then severe acute liver disease and peanut allergies with certain forms of progesterone. So self-treatment strategies for menopausal symptoms. Obviously avoiding triggers, which can be low sugar, incorporating a lower sugar diet, alcohol, spicy foods, caffeine. Some herbal supplements have helped people, like black cohosh, omega-3 fatty acids, soy-based whole foods, lavender aromatherapy, mind-body therapies, like meditation, yoga, and traditional Chinese medicine and acupuncture, as well as exercise. So this is just a chart with what you're supposed to do, but I always tell people find something that you like to do and do 30 minutes 3 times a week and add to it if you would like, and that's usually what's recommended here. So the Women's Health Initiative study, they enrolled healthy women ages 50 to 79 in a study that started in 1993. And the findings have had a significant impact on how doctors and women approach hormone replacement therapy and preventative measures. So they found that combined estrogen and progesterone therapy increased the risk of breast cancer and other problems. In addition, the study found that estrogen, or a combination of estrogen and progesterone, 2 types of hormone replacement therapies, had varying outcomes with chronic conditions, as the evidence doesn't support the use of these therapies to reduce the risk for chronic diseases such as heart disease, stroke, cancer, osteoporosis, and dementia. The study also showed that estrogen alone may not prevent heart disease or other chronic diseases. In 2017, among most postmenopausal women, hormone therapy with estrogen plus progesterone for a median of 5.6 years, or with estrogen alone for 7.2 years, was not associated with the risk of all-cause cardiovascular or cancer mortality during cumulative follow-up 18 years later. And the study is still ongoing. But they reinforce the importance of women making shared decisions with their providers about benefits or risks of taking hormone therapy during menopause. And for example, women younger than age 60 with low to average risk for cardiovascular disease and breast cancer who want to take hormone therapy may experience greater health benefits rather than risks during early menopause to treat moderate to severe symptoms like hot flashes and night sweats. Because I've had patients that never had a hot flash, and I've had people that can't leave their house because they are drenched in sweat. So it's definitely a spectrum, and we have to kind of meet people where they are. Hormone therapy for women, benefits and risks. Many factors affect a woman's decision to use it. And if she uses them, which product or regimen is best to relieve her symptoms? Common factors include age, underlying health, symptom severity, preferences, available treatment options, and cost considerations. The major risks are stroke. Both estrogen and progesterone therapy increase the risk of stroke. That risk goes away, however, as soon as you stop taking it. Blood clots risk increases if you take hormones by mouth. The risk may be lower if you use a transdermal estrogen, such as a patch, gel, or spray. Uterine cancer. If you didn't have a hysterectomy, you still have a uterus, you need to take estrogen and progesterone to protect your uterus. If you have already had uterine cancer, also called endometrial cancer, it's not a good idea to take hormone replacement, although a progesterone by itself might be an option, which you can discuss. But breast cancer, if you're wondering whether hormone replacement causes cancer, there's some good news for women who use estrogen therapy. Women can use estrogen therapy for 7 years before the breast cancer risk increases. The risk goes up after 3 to 5 years for women who use estrogen and progesterone, and their risk might be lower if they take micronized progesterone intermittently and start hormone replacement early. Benefits, there are lots of them. Reduce symptoms, lessen the hot flashes, night sweats, vaginal dryness, and poor sleep, irritability, and the brain fog that goes with them. Vaginal symptom relief, including decreased thinning of the tissue, dryness, such as painful intercourse. If you take low dose oral or transdermal hormone replacement, you may need to add a vaginal estrogen to get relief. So we treat systemic symptoms with oral and transdermal, and we treat vaginal symptoms with local vaginal inside the vagina. And then ease overactive bladder, it protects your bones, lowers the risk of cardiovascular disease. If you start within 10 years of menopause, you could lower your risk, just because estrogen has a lot of good effects on the veins and arteries in your body. Reduces your diabetes risk. Women who use hormone replacement have a lower risk of developing type 2 diabetes. Often trial and error, work with your provider, and as new therapies and guidelines become available, your body and lifestyle needs change over time, and then you can reevaluate that at a later time. Although hormone replacement might not be right for every woman, for some, the benefits outweigh the risks, which is why careful consideration with a knowledgeable healthcare professional is so important. Oral estrogen therapy, most widely used. Some of it does get taken up in your liver, and that can lead to side effects, unwanted ones, which are an increase in high-density lipoprotein cholesterol, associated with a 25% increase in triglycerides, some coagulation, some liver disorders, coagulation factors, and inflammatory factors. It can affect coronary artery disease and an increase in sex hormone binding globulin. Transdermal and topical estrogen therapies are one of my favorites, my favorite forms. They come in patches, gels, sprays, and emulsions, not subjected to getting taken up by your liver. So it's associated with more stable serum levels, and then minimal effect on sex hormone binding globulin, therefore less of a negative effect on sexual functioning. And then there is a risk of skin to skin transfer of small amounts, but it's usually minimal. Adequately powered studies show increase in blood clots and stroke with oral estrogen therapy, but not transdermal. Vaginal estrogen therapy, we kind of touched on that, but there's creams, tablets, inserts, and rings that can deliver estrogen to your vaginal tissues for dryness, pain with intercourse. Usually it's just twice a week, so it's not that much that inconvenient, but endometrial protection is not needed when you use vaginal estrogen, and then endometrial protection with a progesterone is needed with systemic dose estrogen rings. There's two kinds of progesterone. The micronized progesterone is identical to the progesterone that goes in your body, so it's bioidentical. It usually helps you sleep, so I advise people to take it at night. It's the only FDA-approved bioidentical progesterone and contraindicated in women with peanut allergies, though. No systemic topical options except compounded, which is not recommended just because there's not a lot of research, and it's not something you want to be chancing within, keeping your risks of endometrial cancer low. New vaginal progesterone. But that's usually used for infertility treatments and not usually for endometrial protection. But it does fix expensive though. Progesterones, synthetic products with progesterone-like activity. So they're hydroxyprogesterone acetate is the most commonly used and studied in the United States. It's similar to testosterone, so it includes the norethindrone, levonorgestrel, norgestimate. These are the names of certain types of this progesterone. There's also an IUD, and then it's good for 8 years of endometrial protection or for contraception. Bioidentical, this was a marketing term that's not recognized by the FDA and is often misused by compounding pharmacies who inaccurately market them as natural and safer when there's no evidence to support these claims. Yeah, they say that they're chemically identical to hormones produced by the ovaries during the reproductive years, including estrogen, estradiol, estriol, progesterone, testosterone, DHA, and cortisol. The Menopause Society, who I'm certified through, and the American College of Gynecologists have each released position statements against the use of compounded bioidentical hormones and does not endorse any serum, saliva, or urine hormone testing to determine the dosing. There are FDA-approved, extremely effective and bioidentical hormones that are monitored and regulated for purity and safety. Pros of bioidentical hormones: it allows individual dosing and combination therapy, various modes of administration. For those with allergies or intolerance to the FDA-approved therapies, it can be prepared without binders, fillers, dyes, preservatives, or adhesives. Cons: not FDA regulated, do not require proof of claim, and are not held to the same standard as manufactured, and not found to be safer than the FDA-approved formulations in the clinical trials. May even have harms associated with unknown pharmacokinetics like pellets. Lack of monitoring of adverse events, and often not covered by insurance. Testosterone indications and prescribing. Testosterone induces less than 1/10 of those used for males, slightly improves sexual function and self-image, and reduces sexual concerns and distress in postmenopausal women with hypoactive sexual desire disorder, HSDD. Meta-analysis, or when they put all the studies together, show no severe adverse events with physiologic testosterone use. Adverse events and safety concerns may occur with higher doses, and then the long-term safety of testosterone therapy has not been established. Total serum testosterone concentration should not be used to diagnose hypoactive sexual desire disorder. There's no FDA-approved formulations for postmenopausal women, which means it does get made by a compounding pharmacy, and it's often not covered by insurance either. Transdermal versus oral hormone therapy and delivery and risk for adverse outcomes. Risk of blood clots with hormone therapy has been shown with oral estrogen and is greater with estrogen and progesterone than estrogen alone. Observational studies with transdermal estrogen, there's little, if any, increased risk of blood clots. There is a slight risk when oral progesterone is added, but for those with active or a history of a blood clot, first line is non-hormone therapy, and then if non-hormonal therapy is not effective, we should consult with the patient's hematologist before providing low-dose transdermal hormone therapy and discuss risks and benefits. But you may use hormone therapy while going under anticoagulation therapy. Potential hormone adverse events. Uterine bleeding, starting or returning, breast tenderness, nausea, abdominal bloating, dizziness, headache, changes to the shape of the cornea, sometimes leading to contact lens intolerance, fluid retention, mood changes with estrogen and progesterone, particularly with progestin, the second column on the other slide, and then angioedema, gallstones, and pancreatitis. Timing of hormone therapy initiation, less cardiovascular disease, risk associated with hormone use, and potential coronary artery disease and cognitive benefit if initiated closer to the time of menopause. In contrast, hormone therapy used initiated further from menopause may be harmful. Evidence from the Women's Health Initiative, the absolute risk of cardiovascular disease was lower in younger, recently postmenopausal women. The use of hormone therapy within 10 years of the onset of menopause was associated with a lower coronary artery disease risk than if it was started over 20 years from the final menstrual period. Women aged 50 to 59 in the estrogen therapy alone arm had more favorable all-cause mortality outcomes and fewer heart attacks. And then early estrogen prevention study and the early versus late intervention study trial with estrogen suggested that cardiovascular safety of hormone therapy initiated early in menopause based on favorable cardiovascular markers, underpowered to assess the primary cardiovascular outcomes. So, when to stop? Decision should be individualized, and approximately 50% of experience recurrence of symptoms with discontinuation. 20% of postmenopausal women have vasomotor symptoms that persist for 20 or more years. In observational studies in prescription drug and encounter records, more than 10 million Medicare recipients found that the use of estrogen therapy 65 and later and beyond linked to reduced overall mortality, reduction of breast, lung, and colorectal cancer, as well as decreased rates of congestive heart failure, blood clots, atrial fibrillation, heart attacks, dementia. And many of these findings are consistent with prior observational studies, representative of a healthy user effect. So estrogen and progesterone therapy was not associated with benefit in any of these outcomes, with the exception of congestive heart failure. So increased breast cancer mortality was observed with estrogen and progesterone. And then using systemic review methodology, the National Institute for Health and Care Excellence found no evidence for cardiovascular disease prevention with hormone therapy at any age, and a small increase or neutral effect of estrogen therapy on breast cancer. The U.S. Preventative Task Force, using a systemic review approach, found no benefit for primary prevention of chronic diseases, including cardiovascular disease in postmenopausal women. The local estrogen therapy may be continued as long as vaginal symptoms are present. There are risks, hormone therapy and breast cancer risk. Observational studies suggest that hormone therapy does not further increase the risk of breast cancer in women at high risk because of a family history or after both their ovaries removed for BRCA1 or BRCA2 genetic variants. Systemic hormone therapy is generally not advised for survivors of breast cancer, but may be considered when vasomotor symptoms are unresponsive to all the non-hormonal options. And for survivors of breast cancer with genitourinary syndrome of menopause, low-dose vaginal estrogen or DHEA may be considered. There's insufficient data are available to assess the risk of breast cancer with this particular type of medications. Endometrial cancer and hormone therapy. Endometrial cancer is the fourth most common cancer in U.S. women. 90% diagnosed with uterine cancer present with abnormal bleeding. Unopposed estrogen in a postmenopausal woman with an intact uterus increases the risk of endometrial cancer. Low-dose vaginal estrogen doesn't need a progesterone and doesn't increase the risk. And then, but the use of systemic hormone therapy is an option for women with surgically treated early-stage low-grade endometrial cancer. And then vaginal or systemic hormone therapies are not advised with high-grade types of cancers. Endometrial hyperplasia and hormone therapy. So the risk of endometrial hyperplasia, or just the overgrowth of the cells in the uterus without atypia progressing to cancer, is less than 5% over 20 years. However, if it does have atypical cells, the risk rises to 28%. It's in menopausal women with or without atypia can be managed with an IUD usually, or continuous oral progesterone. When you use an IUD to treat this cancer, there's a higher disease regression, fewer adverse effects, and then a favorable bleeding profile compared to oral. And then hysterectomy is generally recommended for those with endometrial hyperplasia with atypia. And then systemic estrogen therapy may be initiated if they do have severe vasomotor symptoms after their hysterectomy. Women taking hormone therapy should be encouraged to report any unscheduled vaginal bleeding promptly. And then use of systemic estrogen alone in someone with an intact uterus is associated with an increased cancer risk for endometrial hyperplasia. And then endometrial protection is always needed with progesterone when you're on estrogen therapy. Progesterone is not required when you're using it vaginally, though, as we've gone over. Ovarian cancer and hormone therapy. Ovarian cancer is a leading cause of gynecological cancer-related death in the United States. There's no satisfactory screening strategy, so by the time it's found, it's usually at advanced stages. The use of oral contraceptives is associated with a reduction in overall ovarian cancer risk. Women with a history of ovarian cancer, the benefits of hormone therapy generally outweigh the risks, especially with bothersome vasomotor symptoms or in early menopause. So the use of hormone therapy is not advised in women with hormone-dependent ovarian cancers, including those types of cancer specifically. Hormone therapy appears to be safe in women with BRCA1 and BRCA2 genetic variants who undergo they're having their ovaries removed before the average age of menopause. And then vaginal estrogen is fine too in this case. So blood clots and hormone therapy. Systemic oral hormone therapy is associated with an increased risk of blood clots and is contraindicated in those with a history. Systemic hormone therapy used with underlying thrombophilia without history of blood clots is a relative contraindication. And then those with a family history of blood clots should get a workup before starting. And then in observational studies, low-dose transdermal hormone therapy was not associated with an increased risk of blood clots. Off-label use of low-dose transdermal hormone therapy may be considered for those with persistent vasomotor symptoms, not responsive to non-hormone therapies, if they are adequately anticoagulated. For healthy symptomatic women aged younger than 60 years old or within 10 years of menopause onset, the favorable effects of hormone therapy on coronary artery disease and all-cause mortality should be considered against potential rare increases in breast cancer, stroke, and blood clots. So hormone therapy is not government approved for primary or secondary cardioprotection, so it's not prescribed to protect your heart. Personal and familial risk of cardiovascular disease, stroke, blood clots, breast cancer should be considered when initiating the therapy. And then the effects of hormone therapy on that may vary depending on hormone therapy is initiated in relation to a woman's age or time since menopause onset. Observational studies and meta-analyses show increased risk of congestive heart disease in women who initiate hormone therapy when aged 60 or younger or within 10 years of menopause. And then women who initiate hormone therapy older than 60 years old or more than 10 to 20 years from menopause onset are at a higher absolute risk of those complications. Screening mammograms. I just threw this in there so we could educate, but the entire reason we screen for breast cancer is to find it early when most are treatable and survivable. Breast cancer is the #1 cause of death in women aged 35 to 54 years old in the United States. Mammography has been proven to reduce deaths due to breast cancer in women screened beginning at age 40, and then 25% of all years lost to life lost to breast cancer occur in women diagnosed before the age of 45. Women at high risk for breast cancer due to known or suspected disease-causing mutations like BRCA1 or BRCA2 should begin screening at least by age 30 to include MRI. And then there's different guidelines, but I have my patients start at 40 and go yearly, but that's an individualized decision as well with you and your provider. Pap smears, generally, when you're between 30 and 65, every 3 to 5 years. I still do it every 3 years with the HPV just to be safe, but there's different guidelines there too. And then colorectal cancer screening recommendations, the guidelines are even younger now because they're finding more advanced cancers in younger and younger people. So starting age 45, you either get a colonoscopy or you can do stool testing to test for cancer DNA in blood. Osteoporosis screening, basically, if you have certain risk factors, you should do it before age 65. Bone density should be measured in the postmenopausal women with risk factors for bone density, low bone density, where knowing the result will influence the clinical management. So those with a history of fracture since menopause, those with no medical causes of bone loss or fracture, 65 and older, 50 and older with one or more of these additional risk factors. So if you have a low body weight, less than 127 pounds, or a BMI less than 21. History of a hip fracture in a parent or a current smoker. These are some resources for you. Menopause.org, that's who I'm certified by the Menopause Society to treat menopause. And that's their portal. They have a lot of, all of the practitioners that have the certification. You can put in your zip code. And then there's the menopause guidebook that you can purchase from them for $15, which is really great too. The Nurse Practitioners and Women's Health.org, they have a lot of great articles as well. And then womenshealth.gov/menopause. That's it. What questions? Anything? Any questions?
I have a question that I should have asked in the very beginning, because I'm
Yeah.
pretty sure you told us in the very beginning, and then the term kept being used and I didn't remember what it was. The basal motor symptoms, which ones were those again?
Hot flashes and night sweats.
Okay.
Gotcha. Yeah.
Okay.
Yeah.
Okay.
And so you mentioned joint pain, and that's typically after, like, once menopause has occurred.
Right. It's usually like in a postmenopausal period, more so as your body gets more and more affected by the lack of estrogen.
Does it happen at all during perimenopause?
A little bit, but not as extensive
Okay.
as in the postmenopausal period. So that's when people complain about it the most.
And typically on their body, like, where do people mostly complain about it? Like
It
hips?
seems to be shoulders, knees, and like low back pain, like
Okay.
hips and things like that, of what my patients have described to me. So
And then endometrial protection.
mhm.
What was that? I put a note that was when we were talking about the vaginal local, the estrogen local, or
Mhm.
I don't know the right term for it.
Yeah, when you use a systemic estrogen, like a patch or taking an oral pill that's going through your whole body, we have to protect your uterus from the effects of that estrogen. So then you always have to be on a progesterone to counteract the effects of that, or it just continuously deposits estrogen, and that can be really thick over time and then turn cancerous when that many cells are in a small space.
Oh, okay.
So,
That makes sense.
Yeah.
So when it says endometrial protection, that means you have to be using the progesterone.
Yeah. Yeah, but you don't
Okay.
have to have it when you're just doing local estrogen, like with the suppositories or creams to treat like vaginal dryness or pain with intercourse.
Okay, cool.
Yeah.
Sweet.
Progesterone and blood clots, how common is that?
Oh, just progesterone and blood
Mhm.
clots? Not very common. That's usually the go-to when you can't tolerate estrogen for whatever reason, like you had a blood clot in pregnancy or just blood clots in certain time periods in your life or have a clotting disorder. So, yeah.
And that would be, but it did say that the locals are safer if you were to go that route, or the
Transdermal.
the transdermal
Yeah.
side. I like the language.
Yes, just because they don't go through the liver, so then they have less effect on the clotting factors that are made in your liver. So,
Okay, so they're like less dangerous, but probably not the first. Oh, that's the question I was gonna ask. The first line of action before you do like treatment with hormone therapy, what were a couple of examples of that? So like exercise and
yeah,
diet.
mind body therapies,
Yeah.
acupuncture, exercise, yeah, lots of different things to try. But most people that come to me have already tried all those things, so
Yeah,
yeah,
right,
it can be maddening to try and do everything exactly right all the time. So,
right,
Yeah.
totally, yeah.
Could you explain a little bit more about when you start, if you were to do hormone replacement therapy, when you start it and how that affects cardiovascular disease risk?
yeah, so the younger you start it, the better. Like the
Okay.
closer to the final menstrual period, the better. Because when you're 60 and over, I mean, you can still have you can continue on it, but starting it after that time, you have more inherent just risk, age-related for cardiovascular disease, stroke, high blood pressure, all of those things. So then starting it later is a little bit more dangerous.
So if you start it sooner but continue on through the later years, you don't see that same risk. as if
Right.
You start it later.
Right.
Oh, interesting.
Yeah, it can sometimes, like, if you have coronary artery disease and you have clots, and then the estrogen kind of melt those clots, and then they can travel to your lungs, and that's, what I've been taught, so,
Okay.
yeah.
But there's benefits, right, if you start earlier.
Mhm.
It's
Yeah, and everybody's different with how it affects them. So sometimes they, like I said, they never have a hot flash or never have any symptoms of the low estrogen. So then generally the risks outweigh the benefits. But if you're miserable and they want us to use the lowest dose for the shortest duration of time. But some people are on them for life.
Yeah.
That's okay too. You just have to accept the risks of what could happen.
Are night sweats and hot flashes sort of the same thing?
Yeah.
They just, one happens at night and.
Yes. Yeah.
Okay. So night sweats are hot flashes, but
At
just
night.
that
At
happen
night.
while you're asleep.
Yeah. Yeah.
Okay, and then there was one slide that said, I think it said something about staying on hormone therapy for like 7 years. Is
Yeah.
that the suggested before the risks start going up?
Right.
with
That's
that?
when the risks start to come into effect then. So that's why they say shortest duration of time to get you through, or a really, really low dose
Yeah,
at those times. So usually around 60, I talk to my patients about, cutting the pill in half or changing the dose of the patch and just sort of titrating down from there, just to
Okay.
decrease risks, but you still get some of the benefits of it too.
yeah. So do you see like more benefits long term if they do hormone therapy and then they stop, taper off at 60 or whenever, than if they were to not do it at all? Is it just kind of to ease the high level of symptoms while during the process
Right.
is the most
But it
important?
affects everybody so differently that some people don't even need it, but some people do need it and then want to continue on it for the duration of their life or just slowly wean off. But my people that have gone down on the doses do pretty well if we just, go down little by little.
Taper it off, yeah.
Mhm.
Yeah, cool.
Mhm.
Do people often increase progesterone through start at 1 and then as you get kind of closer to menopause,
Just with estrogen or
progesterone?
progesterone.
Yeah,
Progesterone really
has
isn't.
improvement.
Yeah. Can you repeat your question?
Do people during perimenopause and menopause and then, after, does the progesterone amount usually fluctuate or do people sort of stay on kind of on
It's
steady?
usually just like a standard dose.
Okay.
Yeah, like 100 milligrams of the micronized progesterone nightly, or like 200, 10 to 14 days in a month if they're on hormone replacement therapy. But sometimes progesterone alone helps a lot of people as well. It can save you from the period irregularities because most of the abnormal uterine bleeding is due to the lack of progesterone. Anything else? Questions? Okay.
Thanks, Brittany.
Yeah,
Great
thank you
job.
for having me.
That was great.
Thanks, everybody. Anybody on Zoom have questions? You can type in. Okay,